I will try to go slowly, and if you do not understand something that I'm telling, just ask, because she's able to translate pretty quick. So I will go slowly. My slides are in French. So I'm happy. This is a picture when I met Sana. I had the opportunity of meeting Sana last year at Mayo Clinic, and we have a good relationship. And thank you, Sana, for inviting me here. Next. I have a lot of conflicts of interest, but now I am happy for that, because this means that research is ongoing in the field of nephrology. And thank you for being interested in nephrology. Next, this is a workshop today. It will be an introduction. Chronic kidney disease, where are we coming now? Chronic kidney disease, where are we going? Where are we going? What we or you need to do, because she told me that some of you are general practitioners, so you are the pivotal of the nephrology. I think that I will have job, but if I don't have patients on dialysis next to you, I will be happy. And take home message. Let's see what I can show you next. So we were thinking in 2020 that the new pandemic was COVID. That's not true. The new pandemic is chronic kidney disease. You guess, you can up your hand. Do you think that in the world there are 8,000 million of people with chronic kidney disease? Who thinks that there are in the world 8,000 million of people with chronic kidney disease? 800,000 millions. How many people is in the world with chronic kidney disease? 850 million of people with chronic kidney disease. So this is much more than people with diabetes and with other diseases. And people does not know. And I will show you, explain to you later why people does not know. Yes. So we have 7 million of people with dialysis, and half of them with kidney transplant. I am proud to say that in Spain we have the biggest kidney transplant program. Yourself, Professor, already know, in the world. But I will be proud in 10 years if I can say that in Spain we are the ones that prevent the people ending up on dialysis, ending up with end-stage chronic kidney disease. You know, because it's good to have a good kidney transplant program, but it's good to avoid the people who need a kidney transplant, and we have new drugs that tomorrow, who is interested, you are invited to come to the talk about the new drugs. So, what is the importance of nephrology and kidney disease? People, Tonelli, that is the current president of the International Society of Nephrology, wrote that this really nice paper. And we are not the first because we are the most handsome in the world. No, we are the first because our patients, when are in the hospital, they need more drugs. They have more comorbidities. They need more doctors. For sure, when we work in the hospital, we have to call the endocrinologist, the cardiologist. It's horrible. They have much more diagnosis, and they are at risk of that. When COVID-19 came, the people were saying the patients with obesity will die. Patients with heart failure or with cardiac myocardial infarction will die of COVID. You know who were the patients at more risk of dying when they get COVID-19? Patients with chronic kidney disease, patients on dialysis program, and kidney transplant patients, the four first patients groups that were dying. And what happened in Spain between 2006 and 2016, that was the second cause after the Alzheimer that increased the mortality. And what is expected to happen, I will not leave, but they are young people here. What is expected happen in 2100. In 2100, chronic kidney disease will be the second cause of mortality. So we should treat these patients to avoid that. Where are we coming from? What's the problem of chronic kidney disease? It's a silent disease. You do not know until you are in the door of the dialysis unit. You do not know, and you have a few symptoms. Is unknown, is underdiagnosed, Ne cree pas alarma social. There is no social alarm. People do not care. If you are in the metro, it happened to me several times. Also, someone asked me, "Are you doctor?" Yes, or in the plane. Yes. What do you work? I'm nephrologist. They look at me. What's that? Nephrologist is that way. They know what's cardiologist, what's urologist. Nobody knows who is nephrologist, but you will help us that people in the future know that. And there is a paternalism. For years, I've spent years saying to the patient what they should do. Oh, you have chronic kidney disease, you should go through dialysis. Oh, you have chronic kidney disease, you should go to kidney transplant. And I think that this should be modified. The future is that the patient decide with information. So, why is silent chronic kidney disease? Because until you are not there with losing 20%, with only 20% of your kidney function, you have no symptoms. Who is the nephrologist here? Only you. Okay. So you have seen for several times patients that came to visit you, and they are at end stage chronic kidney disease, at the end of the disease, and you told them you need to go to dialysis or kidney transplant, and we should think about your future. And the patient look at you. If I feel pretty good, if I feel pretty well, that's not true. You are kidding. And if I haven't anything, I don't have symptoms. And this is a problem. If we do not check the patients, we do not test, we do not diagnose. So I propose how do you test? It's cheap, it's expensive, it's cheap. So this is the test that we propose to check the patient, if the patient has chronic kidney disease. Blood sampling, only a creatinine. You will calculate the glomerular filtration rate. Urine analysis, calculate the albumin to creatinine ratio. It's easy, it's cheap. And please, you can check the blood pressure. It's not difficult, and it will help your patient know. We have this is a kind of calculation in the Spanish Society of Nephrology webpage, and this is a calculator for GFR. When we diagnose kidney disease, chronic kidney disease, when the patient has a GFR lower than 60 and or the albumin to creatinine ratio higher or equal than 30 milligram. And this, in Spain, I'm talking in euros, you can translate, but it's less than 3 euros to have this test. 3 euros? Yeah. 3 euros. It's really it's cheap. You go for a coffee.
3 euros. 3 euros.
Okay, maybe it's cheap. The translation here is different. So, who? Everybody? Who I should check? Patient that is older than 60 years old, diabetes, patient with hypertension, patient with cardiovascular disease, patient with familiar antecedents of chronic kidney disease. So I should ask in my first visit to the patient, do you have any familiar that needs dialysis, that has a kidney transplant, or that has any kind of kidney disease? Obesity, patients with obesity, patients with acute kidney injury. For years, it was thought that acute kidney injury was reversible. That's not true. We thought that the tubular cells duplicate, but now we know that no, that's not true. And if you have acute kidney injury, you have 30% of possibility to develop chronic kidney injury. Because these tubular cells have hypertrophy, but do not restore completely. When you have less renal mass, when you have low birth, when you work, you ask that, we should ask that when we visit the patient. How was your weight when you were there? Well, how was your weight? Because they have risk. And when you don't have a good socioeconomic level, because you will have less food, you will not have a healthy life. And what's the problem? Why is it people does not know? As I told you before, they asked me what's nephrology, and the second answer that they made, your kidney function is not good. One kidney, two kidneys, how many kidneys are not working? So I used to say both of them because when they come to me, normally they have a systemic disease that is making the kidneys not function. But they ask, is one, is the other? And if you biopsy one kidney, how will you know that the other is working or not? So is uncognized, is undiagnosed, and why? Why? Because one, we do not check properly. It happens in Spain. I don't think that we do 100% of our persons that have diabetes have. Well, we do not do. And when we do not put that in the clinical history. If I do not put in the clinical history of the patient that the patient has chronic kidney disease, I will not be treating the patient accordingly. So we have under-diagnosed and under-recognition that our patient has kidney disease that was shown in this study. And it is not a social alarm. What this means, I'm sorry, but if you have breast cancer or if you have acute myocardial infarction, I don't know here in Marrakech, you can say, but in Spain, you don't have special grants for chronic kidney disease. The people with chronic kidney disease is never in the news. And nobody knows, because if you are not spreading what is chronic kidney disease, what will happen with you, I'm sure that you are going in the street and you say, you have chronic kidney disease, yes. And you ask, do you have anemia? Oh, why is related? Nobody knows that the patient with chronic kidney disease have bone problems, have anemia, and have, nobody knows. So why? Because, I don't know, I'm trying to spread that in the world, but it's very difficult. I don't know why, but cancer, everybody knows. Once a week, at least in Spain, we have a program or we have an advertisement about cancer, about heart disease, about stroke, but not about chronic kidney disease. So we need to be in the news, we need to be in the TV, and we need that they know chronic kidney disease. And you as a practitioners are the primary, the ones that should recognize and treat the patient. And I'm sure that you will. In additional, I think that the voice of the patient is crucial, because if I'm going to the health minister of Spain and I say, oh, you should recognize my specialty because I'm nephrologist, blah, 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 they will say, this guy is a crazy nephrologist. That's right, the crazy nephrologist, I like a lot my specialty. But if a patient goes there and says, I'm 3 days per week in a kind of jail named dialysis machine, you should promote prevention and you should promote diagnosis. This will be done. Because it's not the crazy doctor that thinks that her specialty is the best. It's the patient claiming to avoid to go to chronic kidney disease study. For sure, I have this nightmare that I have chronic kidney disease, that I need a fistula. So, where move along? We have to break the silence. People should know what is chronic kidney disease. We have to diagnose, prevention, sensibilization. We need that people be aware of the importance of health, and the patient, we are not fathers anymore. I think that the patient should know and should decide. Now, Now there is a program, we have this program in my hospital that we name shared decisions. We explain the patients all of the possibilities that they have, and they can choose and decide, because actually the one that will go through the dialysis machine or through kidney transplant is not the doctor or the explaining, it's the patient, and it's his life or her life. Message to take home: chronic kidney disease is the new pandemic. I think so. I hope that I convinced you. It's important to diagnose early, because now we have treatment. I think that nephrosis before we were not saying anything because we didn't have a lot of treatments. And now we have treatments for these patients, and I invite you to listen tomorrow our talks about the treatments. It's important that the society, the patient, and the doctors know, and we have to change the paradigm of the treatment of our patients. And thank you very much. This is